Good morning, everybody. Good morning. Thank you all for coming. I know it is Monday morning at 7 a.m. and it's the tail end of the conference, so appreciate you all staying through the very, very end here. So thank you all for coming. My name is Ben Teedy. I'm here with the Global CEO Initiative on Alzheimer's Disease. This is an organization that is essentially part of a broader organization called Us Against Alzheimer's. CEOI is the corporate roundtable of Us Against Alzheimer's and was founded about 13 years ago to help connect patient advocacy voices with the business community and to drive change and innovation in the field of Alzheimer's. Before I begin, I just want to say a thank you to our sponsors and collaborators that are members of the CEO Initiative on Alzheimer's. You can see them all listed here. It's a diverse group of members that includes representation from the pharmaceutical, biotech sectors, as well as other corporate sponsors and nonprofits as well. So we wouldn't be able to do this work without their support. In particular, we're going to talk a lot today about blood-based biomarkers, and we have a subset of funders that have been particularly helpful in supporting our work on this blood-based biomarker work group that you're going to hear about today. So I want to acknowledge the support of AZI, Biogen, Lilly, and Gates Ventures for supporting this work. What you're going to hear about today is a bit of an update on the work that this team has been doing over the last year or so, and then we'll follow that with a panel discussion with our great experts that we have here. But last year, the blood-based biomarker work group was formed and pulled together a group of experts, about 90 in total, across a number of different organizations, academia, nonprofit, biotech, et cetera, to tackle the question of how could we accelerate the adoption of blood-based biomarkers in Alzheimer's disease. We know there's a lot of bottlenecks when it comes to addressing the care and treatment of patients with Alzheimer's. Blood biomarkers are just one of them, but we wanted to pull together a diverse group of experts and see where we could put out some recommendations and publications that would hopefully be beneficial to the field. And so the group was divided into 3 work streams, and I want to also just take a moment to thank and acknowledge the leaders of those work streams. You'll see their photos here. We'll talk a little bit more about what the findings were out of each, but broadly speaking, there were three different work streams. The first was really focused on what should be the performance standards for blood-based biomarkers as they're used in both primary care and secondary care settings. The second work stream was more focused around implementation. How could blood-based biomarkers be implemented into clinical practice? And then the third work stream was really focused around education. How do we raise awareness about the findings that were coming out of this work? And how do we drive that down into the right audiences that ultimately have the greatest impact on patients? And so again, I want to thank all of the workstream leads. I also want to thank Emily Schaller, who you may have met on the way in. She's just outside the room here, but Emily was the one who really spearheaded this work and led it last year. So a thank you to Emily for driving that. I'm going to skip over this slide. We're going to have a video in just a second where Allison Rosen speaks to this, so she'll come back to this one in a second. But just to give you a sense of what the work group will be focused on going forward, we spent last year really focused, as I mentioned, on creating these draft recommendations and content that will be hopefully published shortly in peer-reviewed journals. As we shift ahead into 2024 and beyond, the focus is really on 3 areas. One is going to be around education. This event and others that we'll be doing at conferences this year are really focused on raising awareness among providers. We'll also be looking to develop some continuing medical education and other educational materials that will be useful for both for patients, both in the primary care and secondary settings. We will likely expand into other topic areas as well and address other bottlenecks. As I mentioned, there's many bottlenecks when it comes to the treatment of Alzheimer's patients. As it relates to biomarkers, we know that reimbursement can be one of those, and so we'll look at that as a potential topic for investigation. And then globalizing this work. We know that there is a growing number of patients, not just in the US, but really around the world. In fact, most of the burden of Alzheimer's is outside of the US, and so we know that there's much to be done in other settings as well. So more to come from the work group. We are pleased to announce that we've just launched a new website. You'll see the address here, alzbiomarkerhub.org. A lot of the educational materials that we've developed out of the work group are going to be housed on this site. As I mentioned, there'll be a couple of peer-reviewed publications coming out shortly, but we want to complement that with some infographics and other materials that you'll be able to hopefully have at your fingertips. And this will be a site that we'll update throughout the year with more information and more materials coming from the work group. So feel free to take a look at that when you have a chance. And so with that, I'm really excited about the group that we have brought here today. I want to thank our panelists for joining us. As I mentioned, Allison Rosen was supposed to be here. She unfortunately was not able to join at the last minute, but she was gracious enough to record a video for us. So I'm going to start with a video from Allison, and then I'll turn it over to the panelists that we have here today. So we'll see if we can get this to work, and then we'll go from there. You know what? 1 second. And of course, the sound is not working. 1 second. Give me 1 second.
Alzheimer's disease.
Start that over again, sorry.
Thank you for the honor of being able to present the results of the work group from the Global CEO Initiative on Alzheimer's disease, focused on clinical implementation of blood-based biomarkers for Alzheimer's disease. I wish I could be with you, but I'm with some faculty from Stanford and Harvard on a mission to Israel right now. These statements are my own and do not reflect the views of the Department of Veterans Affairs or the U.S. government. I have no disclosures. So we've known for a while that access to memory clinics is limited. Patients, caregivers, primary care physicians must recognize that there's a problem and make a referral. There are often long wait times for these specialty clinics, and patients must have a collateral source to accompany them. There are also obstacles that may disproportionately affect the ability of individuals from less advantaged neighborhoods and/or minoritized groups from accessing memory care in a timely manner. This is when new Alzheimer's treatments, the disease-modifying treatments, are effective. So you can see here in this paper by Lewis et al., the dark colors are where there's more deprivation, and then the fewer patients coming from those neighborhoods. And also likely delays in diagnosis may be behind the fact that the African-American patients are disproportionately higher in CDR. So the opportunity is that blood-based biomarkers may make these diagnoses, a diagnosis of amyloid positivity, more feasible and easy. But there are ethical issues that need to be considered. These tests should be used judiciously because an Alzheimer's diagnosis conveys risks of stigma and potential for discrimination. They should only be used in people with cognitive dysfunction. They should be interpreted in light of a comprehensive evaluation, and you should know the purpose of the testing in that context. You should consider confounds, sensitivity and specificity in different contexts of use. The tests are rapidly evolving, and there's a group of us working with Michelle Mielke on developing a website to keep you up to date as more data are accumulated. Patients should be engaged in the decision process and the use of these measures. Before the test, they should be undergo informed consent, and we're developing decision tools to help them, handouts, and there should be effective communication of the results and their implications. And there's also an urgent need for education of providers and patients, potentially expanding beyond specialty clinics, the use of these blood-based biomarkers. So the overall goal is to prepare relevant stakeholders for the widespread adoption of blood-based biomarkers in clinical practice to enable a more simple, timely, and accurate diagnostic experience for patients. Workgroup A focused on performance standards. The objective was to define the use cases for blood-based biomarkers for symptomatic patients and define minimum viable test specifications. And that paper is under review. And you'll find in it tables like this, where across different populations, there's different prevalences of amyloid pathology. And that has implications for the sensitivity and specificity, as well as the positive predictive and negative predictive value of the tests. And then, of course, whether you're using it as a confirmatory test or for triaging. The Workgroup B focused on implementation, where I was a little more involved. And the objective is to provide actionable recommendations on implementing blood-based biomarkers in clinical practice. And that will probably be 1 or 2 papers. So here's a simplified patient journey where for a blood-based biomarker test used as a triaging tool. So the primary care is in a general medical clinic, secondary would be a specialty clinic. And then more detailed physician decision pathway with choice points and how the context fits together. And then there's another pathway for a use as a confirmatory test. And then there'll be education tools and handouts that the CEOI produces. So we're just at the beginning. We're laying a foundation for a new era of disease-modifying dementia treatment. And this first wave of treated patients may not be representative, but they can help us prepare the way for everyone else. We're getting ready. If you're interested in this, join us in Agree Dementia. We meet monthly and we discuss these issues and develop educational tools. And here's our website. Thank you.
All right, again, want to say thank you to Allison and wish her well, obviously, on her trip. I think Allison did a great job as one of our work group members laying out both some of the standards that were coming out of that first work stream as well as the pathways that are part of the second work stream. Again, that information will be hopefully in a couple of peer review publications coming out shortly. I think Allison did a great job teeing up both the potential and some of the challenges that we know exist with blood biomarkers. Happy to have more of a discussion about that today. So with that, I want to invite each of our panelists to give a few minutes of opening remarks here. I'll start with Alan Levy from Emory University.
Thank you. Can you hear me okay? Good morning, everybody. Thanks for waking up early and joining us. And I want to thank my colleagues on the panel who nominated me to go first. Damn you guys. All right, so, no, it's my pleasure. I've been doing, taking care of patients with Alzheimer's disease and researching and teaching about Alzheimer's disease my entire career. And I just can't start a session about blood-based biomarkers with saying my perspective is this is a revolution. It's an incredible time in our field, as all of you know. We all have participated in a healthcare system that is just not equipped to take care of people with cognitive impairment and dementia. And so I thought I would just share my reflections on where blood-based biomarkers fit in this ecosystem. And we clearly wouldn't be having, this session if it wasn't, going hand in hand with the first era of disease-modifying treatments. So the urgency that we all have long hoped for of having a treatment that can slow the disease progression and having a treatment that we know relies on very early detection, that the effectiveness of medicines present and future is going to very much depend on having, early diagnosis as possible. And that clearly the ecosystem in healthcare is not set up for diagnosing efficiently, whether it's in primary care and specialty care, and all the confirmatory tests that are needed. And so this is, I think, a cataclysmic time in our field and our careers, and it's a huge opportunity. Blood-based biomarkers, from my perspective as a researcher in this area, it's the wild, wild west. It's incredibly exciting, but I'll say one takeaway I hope I leave you with today is that blood-based biomarkers are not ready for real-time primary care screening at this point. And that, I think we have some work to do. Blood-based biomarkers comprise a lot of different things that can be measured in the blood. I think most of us in the field have recognized that plasma p-tau217, a phosphorylated version of tau at the 217th amino acid, is the sort of the leading biomarker in most people's hands. And there are several different platforms that can be assayed in the blood. And I think the first thing that often is confusing to people is they know that tau is a constituent of the neurofibrillary tangles. This biomarker is a very, very good surrogate of the amyloid in the brain, not of the neurofibrillary tangles. So it's really important to sort of keep that in mind. What are we actually trying to have a biomarker for? So it's not a very good biomarker for the neurofibrillary tangles themselves. Some of us still like to think about Alzheimer's disease as a diagnosis where a person has dementia as well as amyloid plaques and neurofibrillary tangles. And that diagnosis, the criteria are being suggested to change, so it's amyloid alone. I don't think we're quite there yet. So when you think about blood-based biomarkers, what are you measuring? I say it's wild, wild west because we already have direct-to-consumer blood tests out there. We don't have the data to really know how accurate, how specific, sensitive, what the real predictive abilities are. And I think I want to reinforce one thing that Allison said several times in the video. This is meant for people with cognitive impairment. Don't forget that, because especially as we go to direct-to-consumer, all of us are going to be inundated with people who are worried well or misinterpreting results and all sorts of challenges. So I think, as doctors, we can't forget the most important thing is listen to the patients, listen to the family, see who has cognitive symptoms, objectively test cognitive impairment, and then apply the blood-based biomarkers. The reason I said it's the wild, wild west also not ready for prime time in real-world clinics is the vast, vast majority of experience with these blood-based biomarkers come from research clinics where we know the participants are highly educated. They're almost all of them are white. There's very little diversity. And the best studies have occurred in the Netherlands, Sweden, things like that, where they're all Caucasian-based participants. Here in Atlanta, where you are, the diversity of the community is extensive. And we know from our work here, we know from colleagues at St. Louis, that in diverse populations, these blood biomarkers perform differently, depending on the ancestry. So as we think about these cut points, which is the way we're thinking about using these blood-based biomarkers in a triage setting, if a blood level of a p-tau217 is higher than a certain point, we can be pretty darn confident somebody's got amyloid in their brain, which is great. The problem is we can't be so confident if they're Black, or Hispanic, or Asian, because we have so little information about it. So that's one problem. Secondly, there's a lower cut point where right now the state of the art of these tests are most useful if the blood level is below a certain level, because you can be pretty darn confident that a person doesn't have amyloid in their brain. So that's great. You can send them out down a different pathway without worrying about more detailed assessments for potential disease-modifying treatments. But again, the cut points are very different in diverse populations. So how confident can you be if you have an individual patient and looking at individual blood tests? It's a challenge. And then there's about 20 to 30% of people come back with indeterminate levels. Then you sort of scratch your head and go, okay, now what do we do with these people? So it's a revolution, but we're still in a day where those people have to go on to see specialty care to get access to the disease-modifying treatments. And we have major bottlenecks for confirmatory tests, whether it's spinal fluid or PET scans. And they're going to be increasingly difficult to scale, I would say. So buckle up, participate. All of us are going to be inundated with patients. And I guess the last comment I will make is that we have to use these tests responsibly. Right now, the vast majority of people who might be considered for disease-modifying treatments and get a blood test for a triaging purpose, most of those are going to be not eligible for treatment. Their cognition is going to be either most likely too impaired. Most people get diagnosed later than ideally, and those people are going to need services and care. They're going to need education for all sorts of things that we've all known that patients need and their families need, and the ecosystem's not set up for that. And so I just ask that all of us keep in mind, the patients and families, that we make sure that the standard of care remains really high, so we don't just give people diagnoses and then send them on their way. So I'll stop there. Thanks.
Thank you, Alan. All right. Next, I'm going to invite Jacobo Minzer to come up and speak. And I'll just put out a quick primer just to say we'll have a bit of a discussion here after the panelists. And if there's questions from the audience, we'll take those later during the discussion as well. So feel free to jot down any questions you have.
I was standing up, by the way. Sorry.
So several disclosures to start for. I work for the VA, and none of the things that we're going to say have anything to do with the VA, doesn't reflect the VA, and as a matter of fact, for the record, I'm on a vacation day from the VA. So that put to rest. Second, I'm delighted to be in Atlanta. Thank you guys for inviting me, because here you will be very forgiving of my Southern accent. So I appreciate that. Finally, the other disclosure, two more disclosures. I work very close with a company called NeuroQuest, which is one of those in the Wild West. And I got permission from them to show some data. Two more. I'm sorry, you're getting tired of this, but two more disclosures is that I'm a dreamer. So, and I'm optimistic. I used Rogaine for 10 years. So it's clear. But also I'm a realistic. I stop. And I shave my head. So clearly, I would like to start by giving you a vision of the future. The vision that we all would like to see, and where biomarkers fit. And then I will show you 4 slides of the data that I think that we need to demand from everybody. And finally, I will agree with Alan strongly. No biomarker today is ready for prime time. No biomarker, in my belief, should be used other than a research environment, which is control, and I think, and I will be very ambivalent of that, to use it on clinical practice today is wrong, right? If you have any question, I believe you got it. So, let me sell you the dream, or tell you the dream. We know now, we believe now, there is data supporting that the amount of amyloid in the brain will predict your risk to become symptomatic from asymptomatic. We also know, I'm familiar with different versions of this slide, right? That amyloid starts to accumulate many years before an individual becomes symptomatic. And different biomarkers will appear at different stages of the game. So if we could get somebody early enough, then we can imagine a world where a doctor will go, a patient will be 65 or so, or have a risk factor and be a little bit earlier. And at this point, the doctor will take a blood test. And the doctor will say, you know what? I took this blood test. It seems to be positive. I will send you a prescription to take an MRI to be sure how your brain looks and to get a PET scan to see if you have amyloid. And if you do, we'll give you this medication that will be one or several, or a combination of those, but one of them probably will be a self-injected thing that you will stick in your hip or somewhere, on your arm or whatever, and Alzheimer's disease will become a chronic disease rather than a fatal disease. Now, if we get to this scenario, and we will know because the data is out, it's being collected as we speak, so we probably in 4 or 5 years, we know that to be or not to be true. We will need to think that we cannot do a PET scan to everybody over 65, and we cannot follow up. So what do we demand from a biomarker? We like a biomarker that will be easy access, like a blood test, right? That would be, but doesn't have to. Could be saliva, can be an eye exam. That will be low cost. So it can, a primary care doctor will eventually in the future do it. Have to have very high sensitivity. In other words, when we tell somebody, don't worry, come in 2 years, we will repeat the test. We need to feel very confident that we are telling the right person the right information. And you have to have specificity, but we can give a little bit away from specificity because then we will be able to confirm it with another test. So it's like, think about it like something like a mammogram, right? Have lots of sensitivity, but the specificity is not great. So we do then an MRI or a biopsy to confirm what we see. So what do we like? This is the company this is preliminary data. It's published, but preliminary data. But you see here that you see the curve with specificity and sensitivity, and that's what we would like, I think, every company to share, which is about, in the 90s of sensitivity and in the 80s of specificity. But what else we would like to know? This is a curve down. This is cross-sectional data. But if you look at the cross-sectional data, you see here on one end the prediction of the level of amyloid, of the amyloid burden on the horizontal, and on the vertical you see the actual PET. Interesting enough, you see nobody in the upper left quadrant. What does it mean? That there is nobody that's being predicted to have high amyloid that actually has high amyloid. You see also in the lower right quadrant where there is nobody that is not predicted not to have amyloid. But what these things, if some of these things is true, what can I allow us to do? If we have a test that will actually be able to tell us in an algorithm more or less what is the amount of amyloid that an individual have. Well, we know, and you guys know it as good as I, or better, probably better, that individuals, not everybody that have amyloid will develop. And not everybody will accumulate at the same rate. So when do we start treatment? Let's just say that we have these wonderful treatments. We need to know where to start. We need a test. An evaluation would tell us easy access. This individual is here in the curve, and that's the progression. If we get many tests that will allow us to do that, and we can have 2 or 3 that will confirm it, right? Blood tests are not a big deal. Then you will be able to take 3 or 4 points and actually project, right, where the individual will be. Now, this is a dream. Let me take you for a second to reality. And what the reality is. The reality is that what you saw is 500 patients. We need thousands. What we know is that the FDA is only now starting to establish the standards. What we know is that companies are advertising that they have, but don't disclose the specificity and sensitivity. So we cannot judge. So I will finalize with agreeing with Alan. And don't worry, I would not agree with Costas. And that is, I think that when I was a resident, they told me that there is nothing in the blood that will be relevant for Alzheimer's disease because what happened in the blood never will tell anything about the brain. And we need to go to CSF, but it's so complicated, so it's never going to happen. Well, it was proven to be wrong. Also, that we were never able to do anything. They said, oh, we'll take amyloid with surgery. Perhaps we can, That was proven to be wrong. I hope from the bottom of my heart that this time we are not wrong and that the dream is true and what we all have been working for many years. But if you want to destroy it, use it prematurely. If you want to be sure that will never happen, take it to clinical trial, take it to clinical care. Say too much, sell it too much to a non-professional audience. And then you'll be sure that you will create lots of uncertainty, mistrust, and the dream will never come true. Thank you.
Great. Thank you, Jacobo. So our last speaker is Kostas Laketsos from Johns Hopkins, and we'll turn it over for him.
I'm standing up as well. Good morning, everybody, and truly it's wonderful to see this size group come in for an early morning set of ramblings from 4 old white guys. But let me put a tone of caution to this whole discussion, perhaps a little bit more that was said. Alan speaks to a revolution. My caution is this will be a revolution if the prevention trials come in and really show that there is a robust benefit to monoclonal amyloids on clinical grounds in some way that changes the trajectory. I think we all know what the controversies are. Nevertheless, the Wild West actually at some point became the West that we have now. And so being the Wild West now is perhaps a proving ground for where we will be in a few years. And so in that sense, I share Jacobo's dream. I'm going to take a more pragmatic approach and perhaps illustrate some of what I see as the challenges. Having said that, we have a weekly meeting with our fairly large memory center group on Fridays at Hopkins, and I've been made aware of the last week that you can now order these tests from the major companies that do lab tests, and you can get them reimbursed from Medicare. And in fact, we are seeing patients who are getting these tests done inappropriately already. We'll come back to that. So we have to remember that this is about Alzheimer's disease, just so that there's no confusion. We're nowhere near having biomarkers, at least blood-based biomarkers, for other major degenerative diseases. So let's put that aside. The concept of these blood biomarkers is to help us stage this disease. And we're moving from a simpler staging system to a somewhat more elaborate staging system. But the staging system hypothesizes that we have A, T, N, changes in amyloid, changes in tau, changes in neurodegeneration. So the biomarkers we have now available in the blood from the major companies measure A beta species. One of the challenges with measuring A beta species in the blood is that they're not all coming from brain. So that we have a confounding because of peripheral accumulation of A beta species that are also measured from some of these assays. So that's one of the challenges. We have measures of tau and p-tau, various ones, as Alan pointed out, but right now, they don't seem to necessarily reflect the tau state of the brain. They seem to reflect the amyloid state of the brain. So we've got to remember that even what we're calling tau in blood is probably amyloid testing, at least from what we know right now. And then finally, N, neurodegeneration. We perhaps can measure that through following hippocampal volumes over time or in other ways. But all we have in blood right now is this thing called neurofilament light that presumably reflects neurons dying in some way. So we need better N biomarkers, and there are a number of ideas as to what's going to be coming. So these are the challenges of what's measured right now. Slowly, these will be corrected, I believe. We also want to keep in mind that these are at least preliminarily intended to be staging approaches, so we need to see how they work together over time. And we need to see how they work together over time in predicting brain state and also in predicting clinical state. And it's that translation as to how these blood tests ultimately are going to tell us something about the patient's future or current brain state or clinical state remains open. Alan already raised the question about gender and ethnicity, and there's some doubt about whether the monoclonals are really as effective in women as they are in men. Hopefully that'll get dispelled in the near future. But right now there are questions about what populations really can optimally be assessed using these biomarkers. I'm not going to spend much time on what Alan already said, but I will add that we don't know how other neurodegenerative diseases affect these biomarkers specifically. How do they change in DLB? How do they change in FTD? How do they change in Parkinson's? Probably not much, but I think it'll be important to have that knowledge. And then finally, what are the other variables that impact measuring in the blood? So creatinine clearance, how effectively does creatinine clearance impact the measure that you're going to get of any one of these ATN biomarkers? And what about comorbidities? So most of the studies so far have not had people who are very overweight or who have pretty serious chronic heart disease or diabetes or who are on a bunch of meds, the sorts of patients that we tend to see in geriatric psychiatry. So let me switch to where I think the conversation will be most useful, at least for me today, because I came here to learn as much as anything else, which is let's take up a few use cases. So Jacob made the point that he's not going to agree with me, so I'm actually going to do the first shot. Jacob, I disagree with you. I think there already is a use for pipeline for screening into lecanemab or whatever your favorite monoclonal. I think that for some patients who are interested in monoclonal, getting a blood test will make, you could get the answer later. Because I think it's an inexpensive way. So I think that's probably something that is useful now. If a patient who is symptomatic and is theoretically a candidate, and we are thinking of qualifying with an amyloid test, I think getting a p-tau217 might be useful, especially because of the lower cutoff that Alan was talking about, that we could tell a patient, you're really not likely to have the amount of amyloid that'll make a difference. So we should debate that. In geriatric psychiatry, we see a lot of folks with sort of, how should I call them, complicated psychiatric presentations, where we're struggling about whether there could actually be amyloid in the brain, but we do not necessarily have the ability or wish to put the patient in for a lumbar puncture or enough reason to cover the cost of a PET scan. There may be value for, again, p-tau217, because it would be interesting to know whether this very severely depressed patient who is going for ECT perhaps is amyloid positive because they have a high p-tau217. So I think in our perhaps somewhat unique practice in geropsych, this might be a valuable case. What about the folks who have MCI or the broader CIND who are not in the pathway to be qualified for lecanemab? And I think in those folks, my argument would be not yet. Probably because someone who has MCI that looks very much like prodromal AD, it's very likely that they have the amyloid. If they're not going to qualify for Leqembi, what's the point? We can always determine that down the line. Again, a pragmatic clinical approach. It's the unimpaired people that I'm starting to worry about, given that these lab tests are available, and hopefully there will be some control over reimbursing them down the line, but it hasn't happened. So it comes down to the definition of what does it mean to be impaired? Are we talking about someone who has strictly cognitive impairments? Because we had a case a few weeks ago of a very senior colleague in our institution who had dizziness, who was worked up with a very extensive lab panel, who also had the Procivity AD1, shall we call it now, test, which is just right over the cusp, triggered a severe depressive relapse, and she was hospitalized with suicidal ideation. This was careless. It was probably the colleague who ordered these tests probably just wasn't ready, wasn't thinking, hadn't been to the session. But I don't think dizziness qualifies as the kind of symptomatic expression that would make sense in a cognitively unimpaired person to go ahead and do the testing. So this is the area that I worry the most about, is that we are going to be seeing more and more people wanting to know something. And the key issue here is that a positive test's value for prediction is still unknown. This is not like a Huntington's disease genetic test that tells us definitively you carry the gene or you don't carry the gene, and therefore there might be some counseling context in which you can do that test. This is a test whose predictive value is uncertain at this point. So that's really, I think, the primary reason we got to be careful with not ordering them in asymptomatic people without a prior context of cognitive impairment. So I'll stop there and I'll move over a little bit while Jacob responds.
Okay, you know what? Let's do United Nations. Alan, you have any comments?
I'll make one comment. I think one of the most important things, Kostas, you just brought up is sort of the clinical perspective. You know, what are people coming in with? And what we didn't say is that because of the preclinical stages of Alzheimer's disease, we know that about 30% of people, you know, that are elderly, over the age of 70, 75, are going to have a positive blood test. Does that mean that the amyloid in their blood means that in the brain there's Alzheimer's pathology that's contributing to symptoms? I think that's the clinical question that people have to wrestle with. We know at later stages there's a condition called late, limbic-associated TDP encephalopathy. They look sort of Alzheimer-like, but they're typically older. And they're 40% are going to have a positive test, but they probably don't have Alzheimer's disease clinically. They probably have late. So let me just say, don't forget, you keep your clinical judgment.
So first comment to Costas is, because something is there, you don't need to use it. And because people pay for it, doesn't mean that you need to use it or you should use it. Or somebody decide to pay for it is not because they did the extensive evaluation and decided that that's the most appropriate thing. The second is, let's go for instances, okay? If I have a patient that have early MCI or MCI, will qualify for lacutamab or whatever treatment it's out there. And you decide that, the person may be a candidate. Let's say for a moment that the first thing I do is a blood test and it comes positive. And then I do an MRI and it comes that the person have enough blood, or I do a genetic testing as a 4-4. I'm creating expectations on somebody that creating an alarm of something that I would not be able to offer. Then the second issue is, would I have a blood test and it comes positive? Would I not do a PET scan? I would, anyways. So what's the useful of having the blood test in clinical setting, I'm saying, right? When I'm going to do a PET scan anyways afterwards. And since we don't know the exact sensitivity and specificity, and that's an individual that already have symptoms, right? If you tell me, Jacob, and I'm convinced that I want to get lacutamab because my mother, my grandmother, and my great-grandmother died with Alzheimer's disease, and, for God's sake, I have. And you come and you tell me, the test, Jacob, the test that I did came negative. Go home? I said, are you crazy? I have all this history. I want to do me a PET. So since I don't have the ability, because I would not believe you, honestly, and I would not feel comfortable. And I will actually be at risk, now concerned. Oh my God, I didn't do the PET. I forgot my keys. So I think at this point of the development, if the absence of a real, something that will have a sensitivity of 93%, 94% for the saying the negative, and I will be able to follow up to see how it evolves, and the follow-up means something. I think that we need to take a pause, and I think we need to be quiet a little bit. We're all desperate for this, right? I want to do it tomorrow. Before I retire, I might, I want this thing to happen. But I'm not going to create more problems than what these people already have. And I think about I will reveal something personal. My wife does a mammography every year. Every time she goes to the mammography, we are nervous. Thanks God, all of them came okay, but 1 year it did not. And first of all, and then it was nothing, thanks God. But after this year that it didn't come not, my wife, when it comes negative, said, is it really negative? Do I want to do an MRI? And so, again, I think these people, especially when you are quasi-symptomatic, we're not talking about asymptomatic people, because asymptomatic people cannot take lacutamab, right? I don't think that we need to add more uncertainty to a place where there is lots of uncertainty. And if lacutamab was, at these patients at this stage will cure them, okay, you know what, I deal with. But we're talking about that the patients at this stage, as MCI, may be different when we take them very, very early, right? Very early may be that we, as I said, the dream, but we're delaying 2 years and maybe giving a lot of years of uncertainty. So I love to disagree with you, man.
So maybe then a question for you all. So, clearly there's questions. There's we are a bit in the Wild West, right? But I think as was mentioned, the Wild West did become the West eventually. I think the challenge is the status quo right now isn't great for patients either, right? PET scans, are limited. CSF, has limitations in terms of patients have perceptions about it, whatnot. So how do we bridge this divide? Because I think all of you expressed there's a desire to get to this future, right? And I think there's been a few things that have been mentioned, better, clinical data around the efficacy. I think more diverse data, I think, will help get there. I think there's questions about what does the data mean that I think will be answered over time. But, as you look maybe 3 years out, 5 years out, as practitioners in the audience here today, like how do they think about what are the milestones that they need to see? How do they become more comfortable? Because again, I think we would all agree that we can't not do something, because I think the system is not set to handle the fact that there's thousands of patients every day converting and presenting with MCI. So how do we bridge that future to the real West?
I will take that first, and I'm sure that all the others will disagree with me. So I think the first problem is it's not different here than it is with every new technology, with AI or anything else. We need to make parameters of disclosure. I think that it's not right that the company will say we have a test for blah, 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 and will not disclose the data, the specificity, and the sensitivity and the population in which was tested. Those things have consequences in people's lives. So if a company X says, well, I have a thing that measures amyloid, that amyloid is increasing their chances for Alzheimer's disease, yes, that's true, but what's your level of predictability? I mean, when somebody will take any medication, we ask to know the population that was tested, was verified by the FDA. All these things have to be put in place. The FDA needs to put parameters of what is the level of certainty, and again, the gold standard. And also, we need to be clarifying what is the level of prediction that these things have. In the absence of any of that, we need to be very, very careful in disclosing it to everybody. But when you put what makes the Wild West the West is when law and order came to town, right? So I think that that's what we need.
Well, I think it comes back to the use cases, and for me, that's the most important thing to emphasize, certainly in this context. So let me re-challenge Jacob a little bit, because I think it speaks to the broader question. If someone is being qualified for lecanemab, if they have a negative p-tau217 below their lower cutoff, that person should not have a PET scan. Right. And I understand the psychological argument that you're making, but that doesn't come from the negative test. That comes from the history. So let me sort of go to where I think is a much more interesting point. And this was not my thought. This came from Cindy Marshall, who I will acknowledge. Will there be a time where a positive blood test will qualify someone for lecanemab without something in between? And so that'll potentially be the situation where, in order to qualify someone, it'll always be about the blood test, because a test below the cutoff will exclude, a test above the cutoff will qualify, and the indeterminate range, which will hopefully keep getting smaller, might be the person who gets a PET scan. So
I should be sitting in the middle as a middle child here. I'll take a practical, middle-of-the-road approach. All of us get comfortable with a new medicine or new test only by using it. And I think, as things change, the approach that I will take personally, and I think that our team it will take, is do the blood tests, but have the confirmatory tests and see in our real-world experience what it's like. I think we have a lot to learn ourselves, even though we're specialists, in how we're going to interpret them, when we're going to make the determinations, whether someone might be negative on a p-tau test, and whether do we believe they're really negative. Because for me, I know a negative test is much more likely in a black person. I'm probably going to do more PET scans or CSF on those people, even though they're below a cutoff derived for white people. So that's sort of my middle-of-the-road approach. But I think we also have to learn how to educate the primary care doctors, who are also going to be doing a lot of the tests. So I think it's going to be a learning curve. And I think ultimately we need to rely on our professional societies to come up with consensus statements and sort of best standard of care.
So I spoke with a friend of mine. I'm sorry, I'm a storyteller, studied rabbinical school. You have to forgive me. A friend of mine, I divorced 4 times. I'm married 5, at least until last week, I know. And and I asked him, what do you think about marriage? He said, I love it. Obviously, I keep getting married. So I present to you data on something that I'm devoting 12 years of my life to do, on biomarkers. So yeah, I believe in biomarkers. I think blood biomarkers are the future. I think we will need to use, I don't know if p-tau or whatever, and I hope that will be several that we can choose and make a decision. But I think that the best way no, let me reframe it. At the end of the day, all is about trust. That's called placebo effect in some areas. In other words, we call it different. But it's all about trust. When I take we all observe what happened with the COVID vaccine, right? There was no trust. It was scientifically sound, but the public has no trust. So it's critical that this new blood test will gain individuals' trust, the clinician trust and the public trust, because otherwise will create only more problem. And the best way to get something not to generate trust in the public and in the clinicians is to be premature. And I really don't think that we're there. I wish we will, and I hope we will. But I don't think that we can, we'll have a lot to gain by going too fast. And trust me, I want to go fast. But I think that, and again about the rules, p-tau needs to be presented the data in how many people it was done, what's the sensitivity and specificity, what is predicted value, how it correlates with the amount of amyloid load, all these answers, which I may be not reading the literature, but I don't think it has been definitely established.
So ask one more question, but if anybody has questions from the audience, feel free to come to the microphones here. There's 2 microphones. Oops. Sorry. One on each side here. Actually, why don't you go ahead?
Hi, Alan Anderson. Great presentation. I love to see you 2 guys fight with each other. It's great knowing you both over many years. No fisticuffs, by the way. I know you do. I know you do. Anyway, one of the things that I'm thinking about here is, we can control what we do, what we tell our patients. We can't control the press, and we can't control primary care. And as an example, it's an amazing number of patients I've seen in the last month who ask me, how can they get ultrasound treatments to their brain to treat their dementia? And they saw that 60 minutes, and I have one patient that's moving to Morgantown in order to be in a study. People are looking to get these treatments, whether they be diagnostic things or treatments. And I think that's a problem. You can't control the press. You can't control primary care. We can do our job. That's my comment.
Yeah, I guess the question then, what can providers do today? You talk about trust and starting early. How do you start that do you start that conversation now before the tests are available? Do you prime the market so that they understand it as it develops? What should those conversations, knowing that the amount of time with any given patient is very limited and you obviously have to prioritize?
Well, back to Alan's point, we have a very good primary care network and very good connection with our primary care doctors. And so this is something that is a priority. We also have a very robust geriatrics practice, and our geriatricians do a very good job. So I think within an individual health system, to the extent that we can influence the choices and practices of our colleagues in primary care, we can do that. On 60 Minutes, I don't know how to deal with irresponsible journalists. Yeah.
It's a topic for a longer conversation.
I cannot comment on 60 Minutes, only to say that I turned off the TV. That's as much I can say about it. About the system. See, again, a patient comes and said, Doc, I'm concerned. My family had Alzheimer's disease. I forgot the keys or whatever. we are unique because we have the opportunity to put a person into a research program so we can take the blood test in the context of a research program. We're able to do cognitive testing. And if the individual, and then proceed to do, in the context of a research program, to do a PET scan. And if the PET scan is positive, and the gentleman or the lady is an MCI, we will clearly recommend, or not recommend, but open the possibility of receiving lacutamab or whatever others the treatments will become available. Granted, we are privileged, right? Not everybody has that opportunity, has the options, and can give all these options to the individuals. But again, I'm concerned that people will go with some of these tests to the community and take 200, 500 people, put in a room, give a lecture, get them to get a test, and start to get people to lacutamab one after the other, without all the safe rails around. And then the drug, if you give the right drug to the wrong patient, you will not get good results, and then the confidence gets destroyed.
Question over here. Yeah, go ahead.
I just want to make one quick comment about PET scans, and because we've all accepted them as sort of the gold standard, the ground truth. I would encourage us to think a little bit more broadly. So the sensitivity and specificity that Jacobo was talking about for blood tests have been published for each of the FDA-approved ligands. They're not all so good.
That's right.
And there's even inter-rater, differences. And so you do PET scans, even with good quality PET scans, and 5 to 10% of people are going to disagree. So what we're talking about is trying to achieve blood tests that are matching an imperfect test. And so just keep that in mind.
No, actually, more important, and I should clarify, when I'm talking about research and talk about specificity and sensitivity, I'm talking about against quantitative PET scan, which is not what is done in your home hospital, right? In your hospital, you have an impression. A doctor is trained to get and read it. It's not quantitative. In research, and the data I show is against quantitative, so we know exactly how much amyloid that is. And that's when the questions start to be asked, what significant it is.
I have an unusual situation I'll discuss. It may be an option. I do transplant evaluations. A patient who's in her 50s came in for evaluation for NASH cirrhosis. So she does have some hepatic encephalopathy. So the MoCA is low, which is because whether it's hepatic encephalopathy or dementia, it's unclear. She says very clearly, strong family history of dementia, and her primary care PA has put her on Namenda. So I'm in this position now. I have to evaluate and clear her for transplant. MoCA was 16, and she's got 2 years of college, so so I've referred her to neuropsychological testing, and if this blood test shows positive, it may help. I mean, it's less invasive. It's spinal tap for a patient with NASH cirrhosis and bleeding. It's very dangerous. And PET scan, I haven't had good luck with insurance companies paying for it. So what's it?
We're off the record, right?
I'm not going to
You are being recorded.
it's just, the patient needs help, so.
Yeah, they do need help. I guess my first thought is that don't assume that even if they have a positive test that's causing the cognitive problem. So also, as Costas was mentioning earlier, there are a lot of things that affect the blood, the biomarkers, and somebody in liver failure, who knows what the hell the test is going to be, whether it's false positive or not. Or negative. And so, somebody who's got a potentially reversible condition, are there things that one can do to challenge, like, flumazenil or something, to see if you can get a benefit before you put them through a transplant? But I would err towards not assuming they have dementia due to Alzheimer's disease, particularly at that young age.
I would agree with that. A broader question, though, so you must do MoCAs on anybody you are trying to qualify for a transplant. So is this a low MoCA, or is this a typical MoCA?
Well, patient herself complains, too, that she's had problems before. her encephalopathy doesn't coincide with the, MoCA. With MoCA of 16, a lot of them they're more sleepy, and she was not sleepy. So it's a very confusing picture all along. I even talked to the PA that has been taking care of her, and I said, like, where her blood tests started showing liver problem, the enzymes and all that. And he did say that he started, when the enzymes were okay. So, but again, sometimes when you have cirrhosis, the enzymes can be okay if it's too late already. So it's a very difficult situation.
Let me start by saying that every good discussion is based on shared ignorance, right? Because if there is knowledge, there is no discussion. So I will share my ignorance with you, which is an opinion. And if we have a 50-year-old person that have a good reason to have cognitive impairment, and it's probably even if this person have amyloid in the brain, who knows if this person will ever develop to symptomatic Alzheimer's disease? Let's say they does. On the data on the A4 study, only in individuals that started with about 60 centiloids, which is significant amount of amyloid, only 37% over 5 years moved to symptomatic Alzheimer's disease or MCI. So a gentleman at 50 years old with an impaired cognitive impairment, that is most likely related to the liver condition. I will bet that even if the person have amyloid, that's not the main reason why they have. And I will go ahead with the transplant with the knowledge that anesthesia and everything else may actually make the cognitive level worse, but that's a conversation that has to be done. I don't think that is a prescription that fits all, and I really don't think that a blood test will help you a lot.
Thank you.
Thanks. Over here.
Hi. So I certainly don't know the right answer. I think Costas and Jacob disagree, but the best thing would probably be somewhere in the middle. But I did very much agree with Jacob's point about that what made the Wild West the West was the sheriff coming into town. So I want to share from the Huntington's disease world, where we had it so easy compared to this. So of course in the Huntington's disease world, the genetic test was essentially 100% accurate. Now it didn't tell you if the person had Huntington's disease, just like knowing that there's amyloid doesn't tell you if the person has Alzheimer's disease, but it told you for sure that this person was going to develop the clinical syndrome. And the Huntington's disease world, it was and is controlled by a sort of a Cosa Nostra of, tightly connected research sites. And so they were able to determine and promulgate what the standard was for genetic testing, for confirmatory tests and for predictive tests. Almost all the Huntington's gene tests were done by Athena Diagnostic, who kind of worked hand in glove with the Huntington's disease world. And so they said, we only do these tests when they're referred by a physician, and we ask the physician, is this a predictive or a confirmatory test? If it's a predictive test, did you counsel the person? And that would scare away some physicians that didn't really know what they were doing and had just kind of reached out without being HD experts. So the sheriff was the first guy to move into the town in Huntington's disease. He hasn't arrived yet. So I think that this is something that has to be worked out, but the best thing to do is for Alzheimer's experts and Alzheimer's organizations to continue the dialogue about what they think the standard should be and try to make sure that everybody learns that. It is paternalistic to a degree. I mean, Athena could have said, we're going to just start selling HD tests directly to the public. It was a different world when I started in Huntington's disease, and these direct-to-consumer things weren't very common yet. But I think if major organizations say to the testing companies, what you're doing is unethical, and we have a standard, and you need to work with us together in it, and you'll get plenty of tests sold, but let's develop it. I think that industry working with Alzheimer's organizations for people with Alzheimer's disease and working with Alzheimer's experts, in the next 5 to 10 years, there'll probably be an acceptable standard that we'll all feel pretty comfortable with. And I think that it's just an attempt to replicate that, but HD started a very different way and had it so easy compared to Alzheimer's.
First of all, thank you for bringing the Huntington's disease, because that's an example that some of us in private conversations have been using. And actually, I will challenge our host here and to follow what was said and convey a group of people, maybe with regulatory people, with experts on the field, with clinicians, with people from the FDA, European, because you have the ability to convey, and actually at least establish rules of disclosure. So people at least can start to, if somebody said, I have a test for Alzheimer's disease, they have to disclose a minimum amount of information, like how many patients they base the data on, what is sensitivity, what's the specificity, against what was tested. So then the public will be able to be, if they want to take a risk, as Costa said, or a clinician want to take a risk, they know what risk they are taking. Today we don't.
Yeah. That's a point well taken, yeah.
In the basket of tests that are being developed, is there any effort to correlate genetic testing with the other tests that are being done?
Yeah, no, that's a really good question. Absolutely, several of the tests include ApoE testing as part of the blood test. The proclivity one that we had mentioned, for example, are you talking about more broad?
Yeah, is there anything beyond ApoE that's being looked at?
Yeah, not yet ready for prime time. The genetic risks are very small individually, and so even the predictive risk scores that you get from taking 80 plus genes that confer risk don't add much to a family history being positive to determining whether someone's got a risk for Alzheimer's. So it's really driven by ApoE.
So just to answer that, the data show that it's an interesting thing, back to the Wild West, right? Some of the companies, I'm trying to avoid to name one company or the other, the third, their test has really very limited sensitivity and specificity if you don't add some demographics and if you don't have genetic data. The data I showed you is independent of genetic data. So it's an immune profile on itself. Others rely only on the presence of a certain variable in the blood. So they are all different and they are not always relevant. But at the end of the day, we all, I hope, we will end up with an algorithm. And the more, as in every algorithm, the more data you get, the more specific it becomes.
I think you illustrate a really important point, which is any testing depends on prior probability and purpose. And what you're raising here is the question of prior probability. So if someone is known to have a family history, as Alan pointed out, that seems to be very specific, at a certain age has a much higher prior probability. What we don't know is how that factors into the parameters of the test. So I'm encouraging our colleagues who develop these tests to give us what are known as likelihood ratios, because these are good indicators of taking a prior probability, applying a test, and getting a posterior probability of both a positive or a negative test.
Let me show you something. If I can go to my slides for a minute. See, that's what I would like everybody to see. If you see the specificity and sensitivity on the left, but on the right, but the second curve, the light green, that's the combination of demographic, personal, family history, and genetics compared to the one of the biomarkers. That's the kind of data we need, because it goes to your point, right? So I would like everybody that will show these two curves. That's the population, that's the risk population, that's the predictive of all the variables, and that's independent, taking out the data that you have for all these other variables, not including these variables in the model, that you can get better than that.
Yeah, question?
Thank you very much for the presentations. From the beginning of this conference, we have heard of research studies, observations about the use and the orders of biomarkers in helping with precision identification of the subtypes of dementias and for precision prescribing. And this morning, we are told that it's not ready for prime time. Both schools of thoughts are reasonable, I think, in your ways of thinking. So for the rest of us who are in the trenches and treating these patients, the bottom line query would be then, in addition to what Dr. Rosen has already said, that if these tests are ordered appropriately and ethically, then it gives options to patients and their families, because they have the rights and the liberty to choose and to make an informed decision of what they would like to do. So then, the question is, how much work or what work is being done to put guidelines and protocols in place to help us decide as to when is the right time for which patient for these biomarkers to be ordered so that we can treat them properly. I think time is passing. We've done this much research, we have this much evidence. I think we need to speed up in terms of protocols and policies. And being from Canada, I have to wait for another decade before, we get approval from Health Canada after FDA approval.
No, I appreciate the comment, and I think that's a lot of what this work group that was convened by COI was set to do. And you'll see, as I mentioned, a couple of peer-reviewed publications coming out specifying, specific use cases, standards that should be applied. I think there's a question about the data that's disclosed to make an educated judgment about does this meet those standards or not, and how to implement it. And I think there'll be more discussions, certainly to come about then, what are the guidelines and the practices? Because I think you're right. I think it's, finding the practical use cases. I think it was mentioned earlier, I think the likely pathway here will be using this, in combination with other tests as you get familiar with it and start to see it in your own hands, in your own practice. And then over time, I think it starts to give you a better sense of confidence. But any other comments?
Yes, I would really like to leave this conference enlightened and confused.
Yeah, great comments.
So Ben, maybe next year you guys would support a conference to present whatever the guidelines, pathways, and recommendations are. That would,
Again, I come back to my challenge of you, of this, of our host, together with other, just basically everybody that says I have a test have to disclose the amount of information, the basic information, the population, everything, as is in the drug insert. Right? And then people, even if it's not approved by the FDA, at least people in the trenches have the ability to make the decision.
Yeah.
Hi, I want to give some comments, or case examples, as we have said. So one of the other challenges is the fragmentation of the healthcare system and doctor shopping and not integrated health records. So I have a patient, I'm lucky that I am in a tertiary center, so I have a lot of different ways of getting PET scans and testing patients from the preclinical to the clinical stages. And I had a new idea. Patient had amyloid, but had extensive white matter disease, had low B1, low B12, and has remained stable. So the husband of the patient went to a holistic advanced care provider, and then they come back to see me, and I see on the chart that there is like an A-beta plasma and a new MRI for the patient. And it's like, why is this being ordered? I mean, you have amyloid, you have these other things, you have remained stable, and actually lecanemab is dangerous for you at this point. And I think this is one of these things where is the going by protocol, and it's like, oh, the person I see in clinic says I have memory problems. Let's order a battery, and then later let's figure out how to deal with it. And actually, I guess they didn't gather a good history and saying like, oh, I already seen a neurologist, and they told me I don't qualify for this treatment. And so this was something I explained them and all of this, and actually the patient gave me a hug after she left, so it was it was a good way of finishing like my clinic day. But this is the other thing is when I first saw the brochure of like a company about the A-beta plasma, it didn't even say what assay they were using, and I think that's one of the things. And now things move, and every time I get asked to talk about blood biomarkers, is like whatever I say today in 3 months might be completely wrong, and then I will tell you a different story. So So they have an A-beta plasma assay. Now they have a separate order test of phospho-tau 181, and now they are working on getting like 217 while they keep everything. And so I think there is not much of a thought. It's like I just want to get my foot in, and then we just figure it out how to do it without giving a lot of information. So I think these are all of the challenges. And then I think even before this, people don't have time or don't spend time or don't have the expertise to test. And I have had several people who have come with a dementia biomarker diagnosis were cognitively normal. Then we did a PET scan. PET scan was negative, but the provider just went by subjective memory complaints of somebody, ordered testing without knowing if it was appropriate, got an incorrect read of the visual read of an FDG PET, and then suddenly somebody had the Alzheimer's disease who actually didn't have a cognitive impairment and was biomarker negative for Alzheimer's. So I think that's the problem when there is like no frameworks and guidelines on how to do things, and you bring tests which are not completely proven or are still the field is still advancing to practice. So I think this is like just some case examples I've seen of these problems. I'm sorry, mate, this might not have been a question, but I just wanted to add my experience.
Very good comment, and I would like to, again, the issue that we said that we doctors have this tendency, if it's available, we want to offer to our patients. But then not always we know what to do with it. I would tell you, I started to do Alzheimer's care in 1980s, and there was not a lot to do for these patients. So I went to a clinic. We had a clinic in Jerusalem, and I said, what do I do for these guys? And they said, don't worry, Jacob, just, put a white coat, put a stethoscope around your neck, as if you were a real psychiatrist, a real doctor, sorry, and take blood. And I said, why are you going to take blood? Because it's a serious disease. If you take blood, you are a serious doctor. 6 months later, I have just a very small refrigerator that the city of Jerusalem gave me. So I took the blood and put it in the refrigerator, right? After 6 months, the refrigerator is full. People come to me, this is a true story. People come to me and said, are you going to take my blood? And I said, I didn't have where to put it. So, and it felt kind of bad to throw away the blood, right? And we use it, we use it actually to develop an assay. It was good. But again, people have this need to do something about it. And we doctors have the need to do something about it with them. But we have to be very careful to be sure that we're going to have any meaningful information that will be useful for to make the decision making of the treatment and not make it more complicated and more difficult.
Thanks for those comments, John. Couple thoughts based on your comments. One is I'm concerned that the uncertainties we've been discussing all morning are just going to raise more questions and more doctor shopping, right? Because all of us are still learning, and a lot of patients are just going to be confused. Second point about that is your approach to that is to take time to explain things, and that justified the hug, right? How many patients have the time to do that? Third comment is really just a suggestion. Try dyeing your beard gray or something, and they'll trust you right away. So.
Oh, and also, I guess another example, I guess, on the other end. So I had like some patients that were in the pipeline for a clinical trial, and then they were screened through blood, and they screened out. And so they still had a family history. They had one APOE copy. So I said, are you interested to enroll in our observational study? And so 2 out of 6 came back positive in the PET scan and went back to the clinical trial. So there is a challenge like also this way where we screen out. And these things have changed because the blood biomarkers are moving, but I think that's like of all these examples when you have direct-to-consumer testing and people don't understand with what test and how good its test is. And actually, there is also the risk that people have false safety when like not very accurate tests are being used. So I think it goes both ways. It's not also over-diagnosing at preclinical stages that might be asymptomatic for a long time. It's also missed opportunities of treatment when you use tests that are not that good, but are already out.
Yeah, appreciate it. So really great discussion. I appreciate everyone being here. I'm going to put one last maybe quick question to our panelists. I know we've had a lot of ideas come up and a lot of good discussions. If you could have, I'll give you the power of a magic wand, you could make one issue resolved in the next year. You could fix one problem. What's the one thing that you would love to see addressed in the next year?
Results of the prevention trials, because that's going to change everything either way.
Reimbursement for caring for patients.
Don't say it better, Rogaine.
I hate to finish my last comment agreeing with Costas.
Yeah.
But I think the single most important piece of information now is to know if we reduce the amount of amyloid before the individual becomes symptomatic, can we really stop the progression of the disease and transform Alzheimer's disease from a fatal disease to a chronic disease, because that will drive everything else.
Yeah, great comments. Well, I appreciate everybody, again, joining today. I think it's been a great discussion. I think this is, as we said, it's a bit of the Wild West, but we're optimistic that the Wild West will become the West. Certainly law and order will help, the sheriff coming to town, but I think, the other thing that made the Wild West was the people, right? People came to the Wild West. People were not afraid of the Wild West. They knew it was the Wild West, and they still showed up. And you all showed up here today. We know that this is not going to be a linear path. This is not going to be a direct path, but it's going to take effort from everybody to learn, to educate, to spend the time with their patients, and to get comfortable with this, get comfortable with the uncertainty. It's going to be uncertain, but I think we all know that we can't just keep going forward with the status quo. And that's how we're going to settle this Wild West. So thank you all for being here, and have a safe travel home today.